Hi everyone, today we are going to present on the childhood management of asthma. Every clinical decision we make has the potential to change a child's life. That brings us to the question, how could evidence-based care reduce asthma hospitalizations, and how can we, as future NPs, make clinical decisions that prevent pediatric asthma attacks before they become emergencies? This question highlights why evidence-based asthma management is so important. Asthma is one of the most frequently encountered conditions in primary care, so we need to be familiar with recognizing, diagnosing, and treating this commonly occurring airway inflammatory condition to prevent adverse outcomes. It's imperative that the condition is caught on time to improve outcomes, and this often starts when the child presents to our primary care clinics. Poorly controlled asthma can be deadly, so we have to be vigilant, making early recognition and effective management essential. And following evidence-based recommendations is the key to asthma control and keeping kids out of the ERs and hospitals. Asthma is a significant pediatric chronic health condition, and it's one of the leading causes of emergency department visits. It's also the main factor for missed days at school, as asthmatic kids miss an extra 2.3 days on average yearly compared to their healthy peers. In addition, it was estimated in a study a few years ago that the annual costs associated with pediatric asthma were $5.92 billion in our country. This places a significant economic burden on U.S. healthcare system. All these outcomes highlight why achieving and maintaining good asthma control is very essential. As future APRNs, we have a critical role in recognizing asthma early, making accurate diagnosis, selecting the best therapy, educating patients and families, and preventing exacerbations before they become emergencies. These decisions should be guided by the best available scientific evidence. For this presentation, we will focus on the use of Global Initiative for Asthma, or GINA guidelines, which provide asthma diagnosing, management, and prevention recommendations and offer comprehensive step-by-step recommendations for optimized therapy, and some other clinical information to reduce hospitalizations and enhance quality of life among children. Asthma is a long-term respiratory condition with several clinical presentations, most of which involve chronic inflammation of the airways. The hallmark symptoms of asthma include cough, wheezing, shortness of breath, chest tightness, and some symptoms varying in frequency and severity. Several factors increase the risk of developing childhood asthma, including history of allergic conditions, frequent respiratory infections, low birth weight, exposure to secondhand smoke, lower socioeconomic status, and environmental air pollution. Upper respiratory infections are often the most common trigger in pediatric patients. Other common triggers of asthma include exercise, cold air, allergens such as pet dander or pollen, stress, viral infections, and a variety of smoke. Also, children can develop new triggers as they grow. Asthma cannot be cured, but appropriate evidence-based treatment, such as the one outlined in GINA guidelines, enables most children to achieve good symptom control and lead active lives.
According to the GINA guidelines, diagnosing pediatric asthma requires both a thorough clinical history and objective evidence of variable airflow limitation. Children commonly present with recurrent wheezing, cough, chest tightness, or shortness of breath, with symptoms that often worsen at night, during exercise, or following a viral illnesses or allergen exposure. Whenever possible, the diagnosis should be confirmed with spirometry, showing reversible airflow obstruction, particularly in children 5 years and older. If spirometry is unavailable, peak expiratory flow variability may be used, and bronchial challenge testing can be considered when the diagnosis remains uncertain. Confirming asthma objectively before initiating long-term controller therapy helps reduce misdiagnosis and ensures children receive appropriate evidence-based treatment. Although asthma is common, several conditions can present with similar symptoms, such as viral respiratory illnesses, foreign body aspiration, and vocal cord dysfunction may all cause wheezing or chronic cough. Children with persistent symptoms despite guideline-directed treatment or unusual clinical features should be evaluated for alternative diagnosis before escalating therapy. Recognizing these conditions early can help prevent misdiagnosis, avoid unnecessary treatment, and ensure children receive the most appropriate management for their underlying condition.
Hi everyone, I'm going to be talking about pediatric asthma management, goals, and the foundation of therapy. The primary goal of pediatric asthma management is to prevent exacerbations while allowing children to maintain normal activity and lung development. GINA recommends that treatment be individualized and emphasize inhaled corticosteroids as the cornerstone of therapy because airway inflammation is present even in children with mild asthma. A 2021 study by Jackson and Barcherier, published in the Annals of Allergy, Asthma, and Immunology, further explained that ICS, or inhaled corticosteroid therapy, effectively prevents asthma exacerbations through several individualized dosing strategies to include age, asthma severity, risk factors, comorbidities, caregiver preference, and proper inhaler technique. This process allows clinicians to personalize treatment based on the child's phenotype and clinical presentation. So, as you will see, the most significant change in asthma management when following GINA guidelines is the move away from short-acting beta agonists, or SABA-only treatments. GINA no longer recommends treating asthma solely with short-acting bronchodilators because they relieve bronchospasm without addressing the underlying airway inflammation. The study previously discussed similarly concluded that inhaled corticosteroids are highly effective in preventing asthma exacerbations, whereas SABA-only treatments only reactively treat asthma symptoms. And furthermore, the poor adherence to controller therapy and over-reliance of SABAs have contributed to preventable morbidity. We now find that ICS therapy can not only significantly decrease severe asthma exacerbations and asthma mortality rates, but also decrease asthma-associated hospitalizations and increase lung function. The Jackson study actually found that there was a 35% reduction in exacerbations found in preschool-aged children who use intermittent ICS treatment. So now that we know that there's a shift in treatment modality, how should this be implemented? Well, the GINA guideline recommends a stepwise treatment approach for not only adults and children 12 years and older, but also a separate approach for school-age children 6 to 11, as well as another one for children younger than 5 years of age. For all ages, treatment intensity is adjusted according to symptom control and future exacerbation risk. For this presentation, although we will be focusing on the 6 to 11-year-old track number 1, which is recommended if at all possible. For children with infrequent symptoms, Step 1 recommends using a low-dose ICS whenever a short-acting beta agonist or SABA is used. If symptoms remain uncontrolled and become more persistent, Step 2 recommends a daily low-dose ICS therapy with your SABA as needed. The goal is to treat airway inflammation early instead of waiting until symptoms worsen. If you need to move to Step 3, a low-dose ICS long-acting beta-2 agonist LABA combination inhaler can be used, or a medium-dose ICS may be prescribed. Clinicians may also decide to prescribe a very low-dose combination ICS and formoterol inhaler as both a maintenance and a reliever, which is known as MART therapy. If a patient is still uncontrolled at Step 3, moving to Step 4 includes either reaching out to pediatric pulmonology to help manage this disease process, or a primary clinician may trial a medium-dose ICS-LABA combination or move to a low-dose ICS formoterol MART therapy. Children with uncontrolled asthma, despite Step 5 therapy, should always undergo phenotypic assessment and referral to a pediatric asthma specialist. This individualized approach balances symptom control and minimizes medication exposure. And the key concepts to remember are: always begin with the lowest effective therapy, step up if asthma remains uncontrolled, and step down after sustained control. And then reassessment should be completed every 1 to 3 months, depending on stability. But it is important to remember that pediatric asthma management extends beyond medication. As stated previously, GINA guidelines recommend that follow-up visits should occur 1 to 3 months after initiating or adjusting therapy to reassess symptom control, lung function when appropriate, medication adherence, and caregiver satisfaction. Therapy is adjusted based on symptom control and the child's risk for future exacerbations. If asthma is uncontrolled, treatment is stepped up, Once good control is maintained, therapy can be stepped down to the lowest effective dose, helping to maximize control while minimizing medication exposure. And at each of these follow up visits, every 1 to 3 months, depending on patient stability, Gina recommends that every child and caregiver receive education regarding inhaler technique, symptom monitoring, and a written asthma action plan. So, next, Melissa's going to discuss with you guys further the quality and strength of evidence used to build these GINA clinical guidelines. Thank you.
Before we discuss the specific recommendations, it is important to recognize why clinical practice guidelines matter. They translate high-quality research into practical recommendations that help clinicians provide consistent evidence-based care while improving patient outcomes. The Global Initiative for Asthma, or GINA, is considered the international standard for evidence-based asthma management. Its recommendations are updated every year to reflect the latest research, ensuring the clinical practice evolves alongside new evidence. One of the most significant changes in recent years has been the shift away from relying solely on short-acting beta agonist, or SABAs, toward introducing inhaled corticosteroid-containing therapy earlier in the treatment of pediatric asthma. This change reflects growing evidence that addresses airway inflammation early can reduce exacerbations, improve asthma control, and ultimately lead to better long-term outcomes for children. We will review the GINA guidelines and the evidence supporting these updated recommendations. The first recommendation is to use a low-dose inhaled corticosteroid, or ICS, whenever a child with infrequent symptoms uses a SABA. This recommendation has grade B evidence and is supported by randomized controlled trials showing significantly fewer exacerbations compared with SABA-only treatment. For children with persistent asthma, GINA recommends daily low-dose ICS therapy. This recommendation has grade A evidence, meaning it is supported by multiple high-quality studies demonstrating better symptom control, improved lung function, and fewer asthma exacerbations. The third recommendation emphasizes regular reassessment using a step-up or step-down approach. At each visit, clinicians should evaluate symptom control, adherence, inhaler technique, and risk factors. This individualized approach improves asthma control while avoiding unnecessary medication exposure. One of the most significant changes in pediatric asthma management has been the shift away from treating mild asthma with SABA alone. Historically, treatment focused on providing rapid symptom relief, but research has shown that while SABAs relieve bronchospasm, they do not address the underlying airway inflammation that is present even in mild asthma. As a result, children remain at risk for severe exacerbations despite having infrequent symptoms. Based on this growing body of evidence, GINA now recommends introducing inhaled corticosteroid-containing therapy beginning at step 1. The evidence supporting earlier inhaled corticosteroid use is both strong and consistent. Research demonstrates that initiating ICS therapy early reduces severe exacerbations, emergency department visits, hospitalizations, and the need for oral corticosteroids. At the same time, it significantly improves lung function, enhances symptom control, and improves overall quality of life for children with asthma. These findings show that treating airway inflammation early not only improves day-to-day asthma control, but also prevents serious complications, making asthma management both safer and more effective over the long term. These findings have important implications for clinical practice. The evidence clearly demonstrates that early ICS therapy addresses the underlying inflammation responsible for asthma rather than simply providing temporary symptom relief. As future nurse practitioners, this means moving beyond treating acute symptoms and focusing on long-term disease control. By initiating ICS therapy when indicated, regularly reassessing asthma control, ensuring proper inhaler technique, and providing ongoing patient and caregiver education, we can reduce exacerbations, improve adherence, and achieve better long-term outcomes for children with asthma.
In conclusion, the GINA clinical practice guidelines provide an evidence-based framework for diagnosing and managing pediatric asthma. The recommendations emphasize confirming the diagnosis, initiating inhaled corticosteroid-containing therapy early, and using a stepwise approach to individualized treatment. Research has consistently shown that these strategies improve symptom control while reducing severe exacerbations, hospitalizations, and asthma-related complications. By combining appropriate pharmacological therapy with patient education, inhaler technique training, and regular follow-up, healthcare providers can significantly improve long-term outcomes and quality of life for children living with asthma. This concludes our presentation. Thank you for watching.